been giving me a sense of, I've never been addressed with my full name ever. So it's been like long name, but most of them call me just Jebasingh. That's my usual name, and brings me back memories of Pondicherry, where we used to come from CMC Vellore for the Spandan, the annual fest, as the hockey captain and the guitarist for the music team. After that, been coming regularly to JIPMER to take classes for the postgraduates once in a while. Now, after COVID, not been coming. I think this is the first time since COVID started coming for a CME. And I would take this opportunity to thank the organizers for having invited me. This is a totally different concept in the management of malignancies, because as Dr. Arun pointed out, I'm actually too much of pressure on me so that I'm not going to teach anybody. It's just going to share whatever I know, and many things which I learned once we embarked on this journey of hyperthermia. Initially, it was not something which we knew about much. Even during, as Dr. Arun said, even during our UG days, we never learned so much. In postgraduate days, even during my MD in oncology or DM in onco, hyperthermia was not really discussed about. And when this concept came to me, it was quite new. And I'm a person who tries to take up anything which is new, which has got some data. And I would probably share with you the data which I've got, which justified in me taking up this procedure in our hospital. Because I don't take up something which is not useful. So that is something which I'm already very, very clear about. And lots of data are there. Most of the studies were done in Germany, because hyperthermia was initially promoted by Germany, the concept of hyperthermia. Then Asian countries, which are slightly reluctant initially, picked up, and now Korea is the leading partner in this concept of hyperthermia. And I'll probably go into the first slide. And as the compere said, there was actually one of my first few slides. What the medicines don't heal, the lance would heal. Lance, they generally mean about the knife. And what the lance could not heal, temperature can, or heat can. So that is the concept of hyperthermia. And this was one concept, because even during COVID, you know, there are lots of studies which were done in the intensive units, even way back in 2015-16, where studies were done in ICU patients who are admitted with sepsis and fever. One group given antipyretics, one group not given antipyretics with the routine care. The people or the patients who were not given antipyretics actually did well. They say fever is the immune response, or any temperature rise of above 1 degree can kill the infection. So that was the concept in that study, which was proven. Multiple studies have been done even after that. So even for malignancies, that is the concept. Any increase in the temperature of a tumor can lead to better cancer control. So that was the concept. And even the reason of this concept of hyperthermia is right from very old days, where patients who were having advanced cancers, when they had fever, the tumors were regressing. Fever for a different reason. So these were the anecdotal causes are picking up by the people in the West at that point of time, and then contributed to the development of hyperthermia and the treatment of cancer. Because they found out that patients who had fever for a different reason had control of their cancers, which are normally very resistant to therapy. And after hearing that Dr. Arun was a dermatologist, I wanted to show one slide. That this took me a few minutes, because I want to insert one slide of melanoma, because we all know melanoma is a very resistant tumor to treat. And I will show you one photograph of this was again from the literature, a person who got cured of melanoma with hyperthermia. So that is something which I wanted to share about. Next slide, please. Yeah, that's fine. And next slide. And again, this was one of those anecdotes which they say, you know, if a good physician is one who is able to produce fever, so that there is no need for medicine, because fever per se can control many infections. So this was actually a very old saying, which was now proven in one of those studies in the ICU, where antipyretics it actually did not produce a benefit compared to without giving antipyretics. Next slide, please. And again, this was the one which I earlier alluded to. Patients who developed fever due to a different cause had control of their tumor. So this was again observed and then contributed to the development of hyperthermia. Next slide, please. And this was again the another point which I alluded to, where patients who had confirmed sarcoma and developed erysipelas, we know that is a bacterial infection with fever, had control of their disease after the episode of fever. So again, this raises this concept of temperature controlling tumor. Next slide, please. And again, the local temperature increase can control tumor. So this was the initial phases of localized hyperthermia which started to develop. Next slide, please. And this was again in an inoperable uterine cancer, where patients who've been exposed to temperatures above 45 degrees centigrade had excellent survival. Next slide, please. So, few points about the methods of hyperthermia. So, hyperthermia can be given to the whole body, that is using extracorporeal heating of the blood and then giving the blood back to the whole body, just like how we do dialysis. This can be used for extensive tumors. The only problem is the temperature should not be more than 41 degrees. So that is very temperature controlled. Any increase inadvertently can lead to complications. So that is, this should be done in a very controlled group and very carefully done. The next is a regional hyperthermia, where we usually give it for sarcomas, where the blood is taken out from that particular pelvis or from the limb, shunted into the system, heated, and then brought back into the same limb. So this is called regional hyperthermia. We use it for usually we use it for melanomas and sarcomas, which are not very chemosensitive or radiosensitive. We use it for them. These are available. And the local hyperthermia are the common machines which are available. It's the easiest to operate and absolutely non-toxic. There are no known side effects except for some mild blistering or some irritation on the local skin. And this is what probably I'll be talking about today, because this is what is commonly used for most cancers, and this is the easiest to operate, and I think demo has also been there. And I'll tell you about the methods of producing this hyperthermia. Next slide, please. And we've got, just like how chemotherapy acts, there are direct effects and there are indirect effects. See, next slide, please. And the direct effects is when the cells get killed with the exposure to temperature. And 44 degrees are enough to kill a cell. And I'll show you the next slide where it was initially proven. And just a single exposure to 44 degrees centigrade can kill a cell. Even at 42, there are some studies which have found cells getting killed, but after multiple analysis, they have come down to a conclusion that 43 degrees are enough right now. But there are lots of data on that, but 43 to 44 is what most of the data say. Exposure can kill a tumor cell. Why I insisted on a tumor cell is because in vitro, a tumor cell and a cancer cell get killed by 44 degrees. But inside the body, there is a lot of difference in the behavior of the tumor cell and the normal surrounding cell when heat is given. Because the tumor cells don't have oxygen. They are mostly hypoxic, especially the center of the tumor cells, especially in large tumors like sarcomas or melanomas, the center of the tumor is hypoxic. That is why they don't respond well to radiation, because radiation requires oxygen. Without oxygen, radiation does not work. It mainly works by the free radicals. When there is no oxygen, radiation will not work. Again, when there is large tumor, there is extensive compression of the surrounding, the capsule or the pseudocapsule. Therefore, chemotherapy doesn't enter the center of the tumor. There is the one reason why most of these large tumors don't respond to chemo or radiotherapy. But here, hyperthermia works in a totally different way. It works only in less oxygenated systems. So, when you give hyperthermia and radiation together, the whole tumor gets the best treatment. So, that is the main reason why hyperthermia with radiation was promoted, and even with chemotherapy. I will show you some data, and I was surprised to read studies in Italy in 1965 about chemotherapy and hyperthermia. I was really surprised. There are wonderful articles on that. And that is why this concept of hyperthermia, especially in resistant tumors, because as a medical oncologist, I'm in this field since 1996. It's like 25 years since, 25 and a half years since I'm seeing only onco patients. I see close to 300 to 400 patients in a single day. Madness sometimes. And majority of them come after getting treatment from multiple areas, after exhausting every other method, and they come. I never say no, because if I say no, that there is no other treatment for those patients. That is why most of the studies are done with palliative patients, because when there is no other option, you find some way to cure them. And sometimes most of the studies are actually given to me by my wife. She does rounds for me most of the time. Though many of my friends call her the DMO in my hospital, and they say, "Oh, your wife paatangala, okay, right?" So, but then some clues I get from her. She used to say, most of your lung patients come back after 2 years or 3 years with brain secondaries. Why? So that kind of stimulated me to do a study on giving preventive chemotherapy to tumors in the lung which are slightly prone to have brain metastases, especially adenocarcinomas. It is not approved so far, but started doing a study. But surprisingly, we found out that those patients who we gave them temozolomide is a drug which can cross the blood-brain barrier, because most of the chemotherapy does not cross the blood-brain barrier. That's why they relapse in the brain. So when we gave them prophylactic temozolomide, those patients did not have a brain secondary. So there was one more study which we did. So that is why we are forced to find some solution in advanced malignancies. And hyperthermia is one modality, which is why I embarked onto this journey, and which can spare the normal tissue and treat only the tumor, because it acts only in the hypooxygenated areas which are in the center of this tumor. And again, when there is blood supply in the surrounding parts of the tumor, that cools the area, and hyperthermia does not work there. So we can spare the normal tissue and treat only the tumor. Therefore, it has got a tumor-specific effect, and when combined with radiotherapy and chemotherapy, it can do wonders. And I'll show you the data on how evidence-based medicine has proven that giving both together has increased the results. And this was a study. You can go back to the previous slide, please. Yeah, that's one. Perfect. Thanks. So this was the pivotal study which found, this was done in the Chinese hamster ovarian cells, which found that exposure to 42.5 degrees could kill a cell. This was in the Chinese hamster. For a human cell, we narrowed down to 43 to be precise. Some studies have said 44, but predominantly anything beyond 42. So 43 for humans and 42.5. And you can see exponential decrease in the fraction of surviving cells when the temperature was raised to 44 and 45. So this is the pivotal study which proved that exposure to heat can kill a cell. Next slide, please. And for the breakpoint for human cell has now been fixed at 43. Next slide, please. And below the or above the breakpoint, or in the graph below, you can see the killing becomes logarithmic. So it can be like more than 100, it be twice, thrice the number of cells when we heat the cell beyond 43 degrees centigrade. Next slide, please. And it is exponential, but it also is linear. So from 41 degrees to 41.5 degrees, there is increase in the oxygenation of the cell. It helps in the oxygen of the cell, which helps radiation, because radiation requires oxygen. So therefore, exposure to hyperthermia before radiation can have multiple benefit by also direct cell kill and also by indirect effect of improving the oxygen of the cell. Next slide, please. And when you heat it beyond that, there is disruption of the cell membrane and there is extravasation, and therefore we can have chemotherapy acting well when we increase the temperature beyond 42 or 43, sometimes even up to 44. Next slide, please. And you can see that this has been depicted in this graph. At up to less than 44, there is no difference in the oxygenation. But after 44, you can see the hypoxidation cells are getting killed up. Next slide, please. And again, the next indirect effect is the immune response. So whenever we heat a tumor area, it brings in more WBCs, or the immune effector cells, which are the T cells and the B cells, which are useful in killing the tumor cells. So that is the immunological effects of hyperthermia. Next slide, please. And I'll come to the methods of producing this hyperthermia. So the common thing is the electromagnetic radiation or the microwaves, which is the commonest method of production. We can also use ultrasound. But ultrasound has got its own limitations, which I'll come to the next slide. Next slide, please. And this is what we commonly use. It is by creating microwaves, which can increase the temperature. And for superficial tumors, we can heat it up to 4 degrees, 4 centimeters. For tumors which are present in the cavities, like the cervix or rectum, there are needles which are now available, which can increase the temperature at that particular area of interest, and that can go beyond 4 centimeters of 4 centimeter size tumors. Next slide, please. And ultrasound, it is quite easy to produce, but the only problem is the area of interest is limited, so it can be used for small tumors. So that is the only limitation with an ultrasound. Next slide, please. And as I had said, tumors are cells which contain less O2 and they are at low pH. So these are the areas where hyperthermia actually works, and that is why it is tumor specific and it does not produce much side effects, because it has got a normal cell sparing effect, because normal cells have got good oxygenation and good circulation, which cools the cells when we expose them to hyperthermia. And there are some studies to say even one exposure is enough to kill a cell before radiotherapy, and there are studies to say just twice a week exposure to hyperthermia during the course of radiotherapy can increase the cure rate by 100%. That is, 45% curable tumors can be cured to up 90%. So that is the main advantage of having this hyperthermia, because their effects are long lasting. It is not immediate only. Next slide, please. And again, hypoxia and you all know, as I already mentioned about hypoxia, which prevents the effect of radiation. Next slide. And the one more main advantage of hyperthermia is, as we all know, radiation works during the M phase of the cell cycle. So cell cycle has got G, M and S phase. The G is the phase where there is the resting phase, the S is the protein synthesis phase, and the M is the mitotic phase. So radiotherapy and chemotherapy work best in the M phase, when the cell is dividing. During the protein synthesis or the S phase, radiotherapy and chemotherapy don't generally work, except a few chemotherapy drugs which are S phase specific, but not many of them. But hyperthermia is sensitive, it works during S phase also. So tumors, that is why sometimes we give radiotherapy in 2 days in a day. That's called hyperfractionation, because cells which are in the M phase in the morning may become S phase, and the cells which are S phase in the morning can become M phase. So we give radiation twice a day, one in the morning, one in the evening, to increase the cell kill. But that can be done easily with hyperthermia, just twice a week, because these S phase cells also get killed with hyperthermia. And the M phase cells will automatically get killed with radiotherapy. And hyperthermia can also lead to reoxygenation, which will increase the response to radiotherapy. And the other major factor is, whenever we give chemotherapy or radiotherapy, there is DNA damage. But this DNA damage can be repaired by the tumor cells. That DNA damage repair is inhibited by hyperthermia. So once a DNA damage is done and the cell cannot repair it, it dies. So that is why there is one more reason how hyperthermia increases the response to radiotherapy and chemotherapy, because it can prevent the repair of DNA damage. Next slide, please. And most of these studies have been done, and even the US FDA approval is given primarily for these resistant tumors, where in advanced head and neck, sarcomas, melanomas, advanced cervical cancer, rectal cancers, which are not all that sensitive to chemoradiotherapy, are the ones where hypothermia really comes into play, because it can double the response to the routine chemoradiotherapy. Next slide, please. And as you can see in carcinoma of the cervix, when radiotherapy alone is given, the complete response rate is only 57%. But when we add hyperthermia, the complete response rate increases to 83%. And even the 3-year survival rate is from 27% to 57%. So this is again a wonderful achievement in the field of carcinoma of the cervix. Next slide, please. And we all know that breast cancer, when it occurs in the chest wall, is a difficult disease to handle, because those tumors are generally very resistant, especially when we treat it after surgery and they come back, we find it very difficult to treat. Again, in this, when we gave, in the trial, there is more than doubling of the complete response rate when hypothermia was given along with radiotherapy. Next slide, please. And even advanced head and neck cancer is a nightmare for most of us. Even one of my very first international trials, which was published in the European Journal of Cancer in 2006, was on advanced head and neck. Because in Madurai, we used to see a lot of advanced head and neck cancers, people coming with large nodes, large tumor volumes. The cure rate was dismal, 25-30%. That was when we embarked on the study of Raficoxib. Raficoxib is a COX-2 suppressor. Now we've got Etericoxib. At that time, we had only Raficoxib. We gave Raficoxib twice a day along with chemoradiotherapy. The response rates actually doubled. From the cure rates, from 35%, we had a 76% cure rate. The reason being, head and neck cancers are controlled by COX-2. We did a study, even the blood shows high expression of COX-2 in advanced head and neck cancers, and the amount of COX-2 increases with the tumor level. So that is why head and neck cancers are very difficult to treat. And when we give hypothermia along with radiotherapy, you can see the complete response rate getting doubled, and even the stage 4, when we have very little response, the cure rate has come up to 38% versus 7% when radiotherapy alone is given. Next slide, please. And another major problem is glioblastoma. All of us know it is a dreaded disease. Once the patient is diagnosed with GBM, sometimes we say we give up. But lots of studies are being done. Even I've got a study on imatinib in glioblastoma, in recurrent glioblastoma. It does work. And again, hypothermia is one more method of treating patients with glioblastoma. As you can see, the response rates have doubled from 31% from 15%. Next slide, please. And this was a study in head and neck. You can see the separation of curve is so high when radiotherapy is given alone or when combined with hypothermia. Next slide, please. And this was inserted for Dr. Arun, a patient with melanoma showing complete response with radiotherapy and hypothermia, which is very, very significant because melanoma is not at all sensitive. When you give radiotherapy alone, the patient will not respond at all. But when hypothermia is added, the reason was the hypoxic areas are made into oxygenated areas, showing the patient wonderful response. Next slide, please. And I think this is the last few slides. The reason why I put this slide is because hypothermia is effective even with chemotherapy. The 1965 article mentions about chemotherapy, the hypothermia being additive, supra-additive, or independent. So there are chemotherapy agents which are supra-additive, like alkylating agents and cisplatinum, like cyclophosphamide and cisplatinum, or independent. I was surprised to see, even xylocaine, lidocaine, when given with hypothermia, can cure a cancer. A normally non-chemotherapeutic drug can be made chemotherapeutic when hypothermia is given. Oh, wonderful study. So these are things which are wonderfully done along with hypothermia, which is why this topic of hypothermia is wonderful to take up. Next slide, please. And so I think the last, maybe the penultimate slide, as a previously, yeah. So as a direct cell kill, I think we will require 44. With chemosensitizing, we will require 41.5 degrees. And for radiosensor, we will require 42 degrees. Next slide. I think last few slides I've explained already. Next slide, please. These are data from international studies. I've just highlighted them to show that hypothermia is really a wonderful method to increase the cure rate in patients with cancer, a disease which we've so far been finding multiple ways to increase the cure rate. And hypothermia can be one more arm to help us achieve that. You can see I just highlighted for the benefit of the audience. Next slide, please. You can see almost doubling in almost all the trials. The cure rates have doubled. So the concept of hypothermia with radiotherapy and chemotherapy is one of those concepts which have to be taken up to the larger public, because once the patient becomes palliative, it is such a burden on them. One, financially, socially, and also on the government, because if the patient is cured, there is no more expense. For the government, if they come to the government hospital, or for the family, if they're taking treatment in a private hospital. But if the patient is not cured, if they become palliative, it's a lifelong burden. It's such a big burden for all of us. So I think this is some This is an entity which can increase the cure rates, thereby reducing the burden on the health sector also. Next slide, please. And again, the list of studies which have shown, there are some studies which are not proven beneficial. There are some studies which are proven beneficial. I've highlighted the studies which are proven beneficial, primarily in advanced head and neck, rectum, cervix, melanoma. These are the main 4 areas where hyperthermia has been shown to have wonderful results when combined with radiotherapy and chemotherapy. Next slide, please. This is a picture of the machine abroad. Next slide. This is a video of our hospital, which has the machine. I think the video isn't playing. Okay, next slide. Next slide. This there. And the adverse events, very minimal. We've done for last 1.5 years, we've been using it in our hospital. Now, very little. This maximum, you can see some blistering in that area or maybe some irritation. The side effects are very, very minimal. Next slide. So to conclude, hyperthermia alone or in combination with radiotherapy or chemotherapy can do wonders, can double the cure rate, can reduce the burden and increase the complete response and the survival of the patient with cancers. So far, for advanced head and neck, malignant melanoma, sarcoma, esophagus, rectum and cervix. So these are the core areas when these form the main burden of cancers which we see, and these are the tumors which are not commonly curable with the routine treatment so far. So this is one concept and one method which can increase the cure rate and prolong the survival of patients with advanced cancers. And I thank the organizers for giving this opportunity, and I hope I have thrown some light on a topic which has not been commonly talked about. And I would be happy to answer any questions if there are from the audience. Thank you.